All right. Good morning, everybody. So my task is to show you that we don't have enough data to routinely give adjuvant chemotherapy for patients with stage 1 cancer. These are my disclosures. So basically, if you look at patients with early stage lung cancer, we all know that existing therapies do not result in the kind of survival rates and cure rates that we would like. And that's because micrometastases is an early event. And we have learned over the years that giving adjuvant radiation for node-negative tumors is not recommended, or margin-negative tumors are not recommended. So clearly, as one of the audience members pointed out, if your margins are positive, that's incomplete surgery. So you may want to do something about it by either second repeat surgery to complete the clearance or give adjuvant radiation. But in a node-negative tumor with margin-positive disease, adjuvant radiation is detrimental. So what can we do to improve the cure rate? We clearly need to eradicate micrometastatic disease, and that involves understanding the biological factors that would predict who is at high risk for recurrence. And you could do it by adjuvant therapy, neoadjuvant therapy. There's a lot of ongoing efforts to look at customized adjuvant therapy based on molecular or biological factors, and also bringing in new agents, such as targeted therapies in the adjuvant setting. But when you look at the role of cisplatin-based adjuvant therapy, it all started with the IALT trial, which was nearly 2,000 patients with resected stage 1, 2, and 3 non-small cell lung cancer. They all got 4 cycles of, or they were planned to get 4 cycles of cisplatin-based doublets. It was a global trial. And it showed that the 5-year survival rate was improved by 4% with adjuvant chemotherapy. That was the absolute improvement in benefit. And the hazard ratio was 0.86. And this confirmed what we had learned from a meta-analysis in the 90s. And that's exactly what this study was meant to prove. We should also keep in mind that in this trial, the treatment-related mortality rate with chemotherapy was 0.8%. And that number would also come up again in the Canadian trial. So adjuvant chemotherapy is not without consequences, not without detrimental consequences. Now, if you look at the overall survival curve for IALT, you can see here it's relatively modest. The p-value here was 0.03. Now, when you break down the IALT study results by stage, these are very interesting. If you look at patients with node at the bottom, stage 1 disease, look at the hazard ratio here, very close to 1. Essentially, stage 2s and 3s were the ones that did better. And this we've come to learn from studies. The greater the risk of recurrence, the greater the benefit from adjuvant chemotherapy. So in patients with stage 1 disease where the risk of recurrence is relatively lower, we're not seeing the same kind of benefits. Now, the whole benefit from adjuvant chemo in this trial is 4%. And this group derives, stage 3 derives the maximal benefit. So what would you think the benefit here would this be? And we'll look at some absolute numbers as we go along. Now, another thing that came up in the IALT study is when these patients were followed up beyond the 5 years, after the original report, this was a report from 2010, they started seeing some negative consequences. With long-term follow-up, the mortality rate started going up on the adjuvant chemotherapy arm. They couldn't tell us what exactly the reasons were, but clearly there were some concerns about long-term effects. And here you see the hazard ratios by stage 1 again. For stage 1, the hazard ratio was 1.01, which means there was no benefit in the IALT trial for patients who got cisplatin-based therapy with long-term follow-up. Now, how about the most positive adjuvant therapy that's been reported in the literature? This is the Canadian trial, which was stage 1B and 2s, and they randomized patient to cis-vinorelbine versus observation. They reported a 5-year survival improvement of 15% with adjuvant chemotherapy in absolute terms. Even in this trial, the treatment-related death rate was 0.8%. So again, that's a recurring theme, about a 1% risk of death when you give adjuvant chemotherapy. These are the survival curves in this trial. Now, here's disease-free survival. This is overall survival. But if you look at the breakdown between stage 1B and 2s in this trial, here is stage 2's clear benefit with adjuvant chemotherapy. But look at stage 1B, there is no benefit here. All the benefit that we saw in the Canadian trial was from patients who had stage 2 disease. Now, here are long-term follow-up data Once again, you can see here in stage 1, the curves cross. You don't see a benefit with adjuvant chemotherapy with long-term follow-up. Now, perhaps the strongest case, whatever there is this CALGB trial for giving adjuvant therapy in stage 1Bs. And in this trial, they gave carbotaxol versus placebo versus observation in resected stage 1Bs. And this trial showed improvement in disease-free survival, but overall survival was not statistically significant in stage 1Bs. So this is a dedicated stage 1B trial where there was no improvement in overall survival with carboplatin and paclitaxel. Now, they did some analysis looking at tumor size post hoc, and they thought that if you had a tumor that's greater than 4 centimeters, you may have some benefit. But this was based on a very small number of patients, about 100 patients. So this is all the data we have to say that if the tumor is greater than 4 centimeters, you may perhaps benefit from adjuvant chemo. Look at the meta-analysis. All the adjuvant cisplatin-based trials, and this also includes the more recent studies and the older studies. And if you look at stage 1, right at the top, there was a hazard ratio of, this is the ALPI trial, which was negative, where you can see here that the hazard ratio was relatively modest to the most positive Canadian trial. Now, what happens when you break these studies down by stage? This is a busy slide, but you look here, stage 1s, the confidence intervals are all favoring control, not the adjuvant chemotherapy arm. And if you look at stage 1B, even there, it's much closer to 1 than any of the other groups. So this is the meta-analysis of all adjuvant therapy trials using cisplatin. And here you don't see a benefit at 1 or stage 1A or 1B. Look at the hazard ratio for stage 1A with adjuvant chemo, 1.41. And for stage 1B, the hazard ratio is 0.92. So that means there is a very small potential benefit for stage 1Bs, but balance that against a treatment-related mortality of 1%. So what does stage 1 disease constitute in this day and age? In the new staging system, it's a tumor less than 5 centimeters. There's no visceral pleural invasion. There is no lymph node involvement. Now, the case Dr. Govindan showed was a tumor that was 4.8 centimeters. So it's almost, if it was 3 millimeters more, it would have been stage 2. Now, obviously, when you draw these, stage distinctions, it's not an absolute cut between black versus white. It is a continuum in the spectrum, and you're trying to pick a point where the benefit is. But essentially, when you review all of these data, what you will come up with is that for stage 1A, there is no reason to suggest that chemotherapy does anything but harm, hazard ratio of 1.4. In stage 1B, you have to admit that there is no evidence. We may feel that these patients are at high risk, we have to do something, but if you look at the evidence, that's based on less than 100 patients. And last session, we talked about how adjuvant erlotinib data, the phase 2 study is 100 patients, and Dr. Oxnard poo-pooed the RADIANT trial, which had about 100 EGFR mutants. We still don't know the results, but that's all the data that we have to support using adjuvant therapy in stage 1Bs. Remember, we don't have good quality of life data from adjuvant therapy. Now, in a curative setting, detrimental effects in quality of life are different from a palliative setting where you're trying to improve and improve the symptom control for patients. We are more willing to accept temporary deteriorations in quality of life if the cure rate can be increased. However, what level of risk is acceptable if the benefit is negligible? So that's something we also need to think about. Giving 4 cycles of cisplatin to a 73-year-old is not a walk in the park. In an ideal world, we would have very effective chemotherapy agents, better than what we have right now, so we may be able to achieve greater cure rates. Maybe in that situation, we would give chemo to stage 1Bs. Or perhaps Dr. Govindan will come up with, or if he hasn't already come up with, a profile that'll tell us who is going to recur. And then we focus on just treating those patients. Right now, we have no way to identify which stage 1 patient will recur versus who will not. We just know their odds of risk, odds of recurrence, and therefore, you're just rolling the dice. Now, are there ways to find out patients where the chemo that we have will work really well? Well, the ERCC story has been talked about quite a bit for the past few years. Just last month at ASCO, we learned that a customized approach basing ERCC expression in advanced stage disease didn't really lead to a better survival. So ERCC-based treatment selection is not necessarily going to deliver us to the other end. In fact, the French group that was going to do a prospective phase 3 trial stopped after a phase 2 effort because they don't even have an antibody that would detect ERCC expression in a reliable manner. So for those of you who are basing decisions based on ERCC, I think you need to take a serious look at the data. And my own conclusion is it's worthless at this point. So in conclusion, what I hope I have been able to impress upon you is there is inadequate evidence to support the use of adjuvant therapy in stage 1B disease. In stage 1A, we have detrimental data with adjuvant chemotherapy. Now, tumor size greater than 4 centimeters, which is what I suspect the lovely Dr. Wakely is going to make the case for, but even there it's based on 100, 150 patients. And post hoc analysis, they were not pre-planned subset analysis from prospective trials. So these are just people looked at different cutoffs, 3.5, 4, 4.5. What if we set the limit at 4.5? Do we see a benefit? Let's move the bar to 4, let's see a benefit. So this is a fishing expedition where we came up with this 4 centimeter number. We need to confirm that prospectively before we start giving it to patients. And hopefully, better ability to identify recurrence of risk would, in the future, lead to better informed decision making for patients with stage 1 disease. Thank you.
Thanks. Thanks very much, Ram. Thank you.